Hello and welcome to the Surgical Spirit podcast. I'm your host, Dr. Haidar Al-Hakim, the Third Eye Doctor. Pull up a chair and get ready for some candid and uncompromising discussion with experts, innovators, agitators, and influential people from every corner of health and well-being. From inside the hospital to at home in the kitchen, we're leaving no stone unturned in our quest to uncover the secrets of healthier, happier, more successful, and less stressful lives. Thank you so much for joining us, and without further ado, let's meet this episode's guest. Hello, this is Dr. Haidar Al-Hakim, your host today on the Surgical Spirit podcast. And I don't have one or two, I've got three lovely ladies. I'm having a foursome with these three lovely ladies today. So if you can introduce yourselves and let's get going.
My name is Dr. Fizzah Ali. I'm a neurology registrar and editor of Medical Woman magazine.
I am Gayle Hammill. I'm a child and adult psychotherapist.
I'm Dr. Nighat Arif. I'm a GP with a specialist interest in women's health, and I do some of this media malarkey when I can.
Yes, you do. You're really active on that. The first question that I've got for you guys is, do we need men in medicine?
That amuses me. It's funny because I was doing a panel in Edinburgh Medical School and the debate was, is medicine still a patriarchy? And I thought, yes, medicine is still a patriarchy, because I think although we have unique challenges, I think when it comes to women in medicine, we are positioned in society which is essentially patriarchal, I think. Do we need medicine? Do we need men in medicine? Yeah, sure we do, but I think we can still do so much better to further the interests of women in medicine.
Could you give us examples of that? In what way?
I suppose, if you look at wider society, what's the sorts of news that we've heard recently, we've had things about gender pay gaps, and there's no actual sector where there isn't a gender pay gap. Whether you're looking at financial firms or you're looking at communications, the media, and then you've got things like allegations of sexual abuse in Hollywood, and you've got the exodus of female MPs because of sexist comments and things in politics. And I think, in medicine, we also have a gender pay gap. We've had comments about a sexist culture within our own trade union. So I think those things permeate through. And actually, it's not just about organisations, it's also how that filters down to individual female doctors and how they're affected too.
So there's a positive bias towards this narrative. Is that what you mean?
That language is too complex for me.
Is it a kind of a culture that's ingrained within medicine, and this culture hasn't changed? Because at the moment, the majority of presidents of the medical colleges are women.
But this is something that we're seeing more recently, isn't it?
Yeah.
And do you not think when we have to counteract things like unconscious bias, that we have to keep at these things? And actually, just because we have female presidents of royal colleges, that doesn't mean, it means something, but there's still a variety of disparities in other places. So if you think about my own specialty, I'm a neurology registrar, and when you look at higher grade registrars or consultant grades, it's over 70% are male, over 70% male, and that goes across various other specialties, not in things like general practice. And I think that shows that actually it is about cultural change, and we haven't moved enough in terms of cultural change in medicine yet.
And just to take up that point that Fizz has made, actually, when you do have this 70% disparity in regards to the genders, women in medicine are making choices where actually it might suit their home life better. So in general practice, there's something like 60% of the workforce are female. And if you ask them, they'll say, well, I wanted to be a surgeon, I wanted to be a neurology consultant, I wanted to be a gastro consultant or an A&E consultant, but actually it doesn't fit in with my lifestyle. I've got children, I've got a husband to maintain, and that doesn't fit into it. So you have to look at medicine. Does it actually benefit the woman in regards to what she wants to do, or does she have to make sacrifices? And sacrifices is a word that as women I commonly hear, and that's not just medicine, that's almost in almost every field of workforce. In fact, there's a really good study that was done by the World Health Organization that looked at healthcare across the world. And it said that 70% of the healthcare is maintained by women. They will, from nurses upwards, will maintain it. But the top sector, which make decisions, regulations, pay, in regards to, the way the system is set out, is still by men. And it was titled something like "Healthcare Maintained by Women, Driven by Men."
Oh, no.
And that's the World Healthcare Organization writing that. So you look at that and you think, hang on, it's going to filter still through. And that unconscious bias is still there. Women are still having to make active choices in regards to, is this going to suit my lifestyle, or is this going to suit my career choice? Unfortunately, women still can't have it all.
Yeah, and when you look at things like the availability of less than full-time training, I think that's surrounded by a culture of restriction, and I think that's problematic. I think men should be encouraged to train less than full-time as well. I mean, the majority of people or trainees in medicine who are working flexibly are women, and the predominant reason is for caring reasons. So that's just another example of where I think culture in medicine fails us.
Yeah.
And actually, I think if you look at different specialties, you can sort of see, you can maybe get a little mirror image or an insight into what culture is like, because, I mean, surgery is something like 10% consultant, or just, I think it's 13%, something similar, consultant grades in this country are women. And I think that's pretty shocking, really.
But also, you look at the women in that, they will still say to you, I have to compromise childcare, or I've delayed a family, or I've probably not got married. Yeah. But the expectation is that women, her worth is valued on, is she a homemaker?
First and foremost.
And how many children has she had? Then she's a doctor. And that is infiltrated amongst all different cultures. So in my culture, I'm a doctor, I'm a mother. But do you know what? Actually, relatives in my house will say to me, and I'm going to speak Punjabi here, sorry, apni doctory shakri chup karke karya karo. That means do your doctory quietly. And because they will still value your work as it's a second thing. Oh, she's got her degree, that's really good. But actually where her value really lies is she making her husband his 3 meals at a time, and are her kids well
Does
looked
that
after?
frustrate you?
Of course that frustrates me. I think it's almost like a straitjacket, because you're intelligent enough to do your degree, you go through the rigmaroles of the process, and doing medicine, it's so hard. And it is really hard. And it has to be hard for a reason. And you go through that, and then you start making your choices, saying...
It's even harder now that you're working it.
It's even harder than you're working, because then you are made restrictions by your cultural influence. And in this society, I will never be able to walk away from my cultural background. I'm first and foremost a British Pakistani Muslim. And I value that. Highly.
Do you think there's an element of, this is a bit, I'm being a bit naughty when I say this, but is there an element of choice in that and the lifestyle choices you've made?
So in regards to
the sorts of, I mean, I agree there are societal pressures, and I think they are to do with, the way people even talk about women's bodies and ownership of women's bodies, not just how women are in the domestic environment. But do you think that there is... can you control the amount of pressure you receive from that, or perceive?
You do. And that takes a lot of core self-belief in yourself in able to counteract that pressure. But I know I've had to cow down to that pressure, because what I really wanted to do was become a gastro consultant and work up that. But the life of a medical registrar is not worth living. And you know that. And the on-call bleep was my bugbear. And I couldn't do nights with a child at home and all the responsibilities that come after it, because I have to then care for my parents at some point as well. And other relatives that come along the way. And so I had to make a choice that was going to be effective enough that I could practice clinical medicine, that made me happy, be practical enough in my clinical medicine, as well as have that balance with my home life. And that's a choice that we're still making. But if I look at my male counterparts, yes, they do have to make some struggles and make some tough choices, but I wonder if they're on a par to women, and I'm going to put myself out there, and I don't think there are, even if I'm shut down for it. You're looking at me.
I think I'm sitting here, you know, I'm not medical, I'm a psychotherapist, and I'm listening and I'm hearing the conflicts and the restraints on that model, that bias. And in our world, actually, males are not present enough. So we're come from a different place. You know, psychotherapy was always very, you know, kind of white middle classed. People that could have the money to go and afford to train. And we don't have enough males because our young people need males. And often psychotherapists and counsellors are female. Mm-hmm. So I actually sit really interested, and I think actually from my world I want, and in fact I have someone in training, a male therapist at the moment, because I think that is lacking in our world. So it's fascinating to me, the differences.
But can I just ask you that? Is it because psychotherapy is seen as, in quotation marks, a female's role? For example, midwifery is still seen as it's a woman's job, or nurses is still seen as a woman's job.
That's really interesting because, you know, when you look at medical specialties, we were talking about this 70% or greater majority in specialties like cardiology and gastroenterology and respiratory and neurology. But then when you look at the specialties that are sort of more 50-50 or more balanced, there are things like palliative care, geriatrics, and then you're thinking about paediatrics. And in surgery, I think one of the sub-surgical specialties which has more women, I think, is obstetrics and gynecology. Yeah. So you start to think about, are these women playing their roles from their personal life in their professional life?
Yes, there are transference. And there are certain roles that actually you will find that men will just want to take all over. I remember distinctly as an F2 doctor following the coattails of my cardiothoracic surgeon that I was following around, and this poor patient was lying on the bed waiting to ask the cardiothoracic surgeon all the questions about his upcoming surgery. And the surgeon said, there are two people that will save you, Mr. X, God or me. Frankly, God is not here.
I love that.
I was just there.
Was the surgeon a man or a woman?
A man.
Yeah.
I like his ego.
Exactly. And I just thought to myself, the poor patient, because I was the only woman on that team as well as an F2, just looked at me in fear. And you sort of think to yourself, I wonder if a woman would ever be cocky enough to say that.
No, I think if that was me in that situation, more compassionate approach, to be quite honest. But I think it's interesting where our ideas of what women are or can be in medicine come from, and I think that starts quite young and probably earlier than medical school. But if we talk about medical school, I think part of it is to do with visibility and mentorship. I mean, when you were talking, I was just thinking about the mentors that I've had in my life, and I've never had someone who's the same gender or ethnicity as me, you know, and that's fine. But I think it's just quite an interesting observation. Yeah.
Doesn't that mean there's a lot of pressure on you now that you've got a younger generation of females who want to go into the space that you're going into?
Do you mean pressure in terms of mentoring others? I mean, I would say that because of the sorts of experiences I've had, or the things that I'm more conscious about, I feel that I have a responsibility to use the roles that I'm in to facilitate or to help others. And I think that's something that I've learned over the last 9 years. I mean, when I first started sitting in committee meetings, I think I used to be quite quiet and sort of sit there, watch everything that's going on. But more and more I realised that each individual has such an important role to play, and what they bring in is so important. And sometimes part of what I bring in is about being, you know, my gender, my ethnicity, my experiences and background in medicine, because that is unique in a way and it's important to have on the table. I've sat in meetings where we are, you know, talking about organising a conference which is on diversity, on women, and because we homogenise women's experiences so much, we're just sitting there thinking, is this really about diversity?
Is this authentic? Yeah. And it's a bit like, because I'm not in that world, it's a bit like the mental health. Let's talk about mental health. Let's have, events. But actually, are we modelling it? Right. Are we starting with ourselves and modelling what we're asking society and our clients or our patients to do? And I think that's lovely, because you're saying, can I be authentic and true to myself? Is it permissible? Mm-hmm. in this diverse situation, to be honest.
But coming back to your question, Heather, you said, are men required in medicine? From the patient's perspective, they really are, because male patients will want to see a male doctor, female patients will want to see a female doctor, and I think that's fine. Personally, it wouldn't bother me if I was a patient as a female, and the gender doesn't come into it. I just need to see the best person who will be able to help me. But patients still feel, and they have this concept in their mind that the best doctor is a male doctor. There have been so many times that I have, and I think that word that encapsulates that really well is possibly respect. There's still a lack of respect for female colleagues, because they will just make the assumption that I won't get the best service. And I've had that throughout my career. I've had that in general practice as well, where patients have come to see me, and then I'll see 2 days later they've booked in with a male colleague of mine, possibly a senior colleague, because maybe age is a factor that plays in that, because I'm a younger GP at my practice.
And you look 19 as well.
Stop it. I'll take that compliment though. I'm a mother of 3 children. And they will always go, on the whole, about 80 to 90% of the time, it's a male colleague that they'll go to for a second opinion. Now, I've lived with that, that's absolutely fine. But I've genuinely had patients...
You think that's more to do with gender rather than race or anything else?
It's hard to say, but on those occasions, as we're talking about gender today, I would say it's gender. Probably it is an ethnicity.
Is this changing? Do you think it's changing, or is that the
same
as
2020? I did a clinic on Monday, and I saw a patient who saw me, and then Tuesday they went to see a colleague who was male and middle class and white. And I don't know whether that's race or gender but there's something there which clearly I wasn't able to fulfill, which is absolutely fine. I'll take it on the chin. That's part of clinical practice. Patients are more than entitled to have a second opinion, and I would encourage them to have a second opinion. But whether they've done it because of respect. And I've often had patients who will come and see me. I'll call out their name, I'll open my door, and I'll say, "Oh, hello, Mr. Bloggs, I'm Dr. Arif." And I've had a patient who'll stand there and say, "Oh, I was expecting a man."
I just find that really interesting, because...
They will say that to me.
Do you get that in hospital?
I never used to get that. And I worked for a long time in the Midlands, and then I moved to London about over 2 years ago. And I don't know whether it was it is hard to get into London neurology, okay? There's that. Yeah. There's also level of seniority. You've gone up a grade. But I remember walking down the stairs and to meet a patient who was in an ambulance, had come as a stroke call, and the paramedic and the patient's wife were looking for Dr. Ali, and I was just like, "Hello, here I am."
Here. Yeah,
and the other time I walked into clinic, and it was, I introduced myself, I was introduced, and the healthcare assistant in front of me, female healthcare assistant, looked over my shoulder for the neurology registrar, and I just thought, these two things have never happened to me before. What is going on? And that's why I think that, men are important in medicine, because they need to help us and we need to help them with equality. But it's also about, I think there's something about this, that it's not just about being a woman or being a particular ethnicity, it's also other women perceiving you in a certain way. And I think maybe that goes back to how we see women in certain positions in society.
Yeah.
So I think it's complex.
So that unconscious bias, that's
the psyche.
It's the psyche.
The psyche is, what are we brought up with? We're brought up with strong figures. We think back to a primal sense. Who's the strongest to keep us alive in a pack? And I think the psyche is trained to look at that, in some respects, that male figure. And have we really shifted from that perspective in terms of the medical world? Whereas in my world, it's very much they expect the female, and I would have, I'd rather see a female therapist than a male therapist, because I think a female is going to be more compassionate or have more empathy. But that isn't necessarily true, because females can be as unempathic as any male could be.
So stepping away from medicine, Gayle, with that theory, the pack mentality and having the leader at the front, do you think this is why the top 5% are all men? So politics, you look at that, you look at healthcare, you look at laws that are being made, infrastructure, money, bankers.
Yeah, I think there's an unconscious trust there, but I also think there is, in some ways in the male brain, I think there is sometimes more of an ability to cut off and shut off and make decisions that are a little bit more less compassionate, but that's not me saying that a male can't be compassionate, because they can. But I think that's why that happens. And I think there needs to be a shift, because I think women look often to men to do that instead of entrusting in themselves. You said something really lovely earlier about, could I be genuine in what I was really thinking? Can we show strength to one another that we can contain that need?
So that comes to maybe as a female species, if I can say that, we just lack the self-worth and self-confidence.
I don't want to say that. I'm not sure I like that.
You don't like that?
Oh, no. I
don't like it, but maybe that's what we need to be tackling.
I think on an evolutionary basis, I think categorization is quite a helpful thing to be able to do.
Yeah.
And I think in medical school, our teaching is based on categorization. I mean, if you think about the cases that we're presented with, is to do with, a certain gender, a certain race, presenting with a certain set of symptoms. Black child, pain, sickle cell crisis, white child, cough, cystic fibrosis. So I think the problem is that doesn't necessarily help us. I don't know if your comment about self-confidence. There's something about nature and nurture in there, which I'm not sure how much to expand on right now, but perhaps goes back to the discussions about society and culture that we've been having.
I mean, it's a provocative comment, but I've often had colleagues who will say that I probably won't put myself up for this role. I probably won't do this. But then a gentleman that's been in the role for 6 weeks is now her senior. And you look at that and you think, and this is, I'm not just talking about medicine, I'm talking about in other roles.
Is there enough support structure amongst women in order to support each other and move this forward?
I would say probably not. I mean, I think we're trying now. It goes back to what I was saying about mentorship and sponsorship and the sorts of mentors and sponsors that I've had in my career.
Should the onus come from the younger generation, the older generation?
You can't split it. I think it's got to come from both ways.
Both sides.
Both sides, yeah.
But I see a culture of women feeling sometimes threatened by other women. I think that is still very present.
Where does that come from?
Yeah, where?
Well, I think going back to the point about looking to the male and then to be chosen by the male, thinking back to the animal primal sense, to be chosen. So who's going to be the chosen one in that psyche of which one of us is going to be the chosen one here?
It just occurred to me, I mean, Thatcher, she was a woman of her time, and like her politics or not, but her cabinet was all men.
Yeah.
And that was very much at the time debated.
We're
still having that debate in 2020.
Did she want to be the only woman? If we look at her psyche, did she want to be the only woman in that position, or did she entrust men more because she felt that men could contain her? I think that's what interests me about it. I think
and there's more women now in politics.
Yeah.
But they're leaving politics at the same time. I mean, so the overriding tsunami, which is social media, is playing a massive role. People feel almost vindicated to say whatever they want to say about whatever woman is, and the derogatory, awful language that's used, trolling, for example. You just have to look at the Paul Caroline Flack scenario recently. And women are hounded. They're hounded out of their positions. Just recently, you look at Priti Patel and the fact that she's accused of bullying. That's fine, but the way it's termed or the way it's written, it's very much that quotation marks bitch.
So this doesn't happen in medicine. It's happening in politics.
No, I don't know, Fizzah. I think it probably is. It's just not in mainstream media.
I don't know. I've not had any personal experiences of that.
So let's move forward with this. How can we bring this together, form that circle? What would you like to see, Nighat, in sort of 5 years' time?
Yeah, I think definitely that the structure way the NHS is in regards to supporting women up the career ladder has to change. So it has to take into account training, less than full-time training, looking at the way they do their nights and incorporating childcare and the caring roles that women do, but also looking at men who have those roles as well. And that has to come from a partnership. At the minute, it's not them and us. It has to be just us. And that's a difficult thing, but small steps are being made, and having conversations like this allows...
Any organisations out there that people can contact or magazines or?
Yeah, so there are. So Women in Medicine magazine is trying to empower women within medicine across all specialities, is doing that. General practice is very much empowering women. It's taking into less than full-time roles. If a woman goes on maternity leave within her training, she's full paid on maternity pay. That changes once she becomes a self-employed GP, but that's still a contentious issue. And I know that changes are happening within my own Royal College of GPs. There's small steps. Yes, of course there's small steps. And things will take time, but we need to be having this conversation. I keep saying 2020 is the year of the woman. We've already had, leap year. Women are asking for their own proposals.
Yes.
So let's just ride this.
Yes,
for
let's
as long as we
continue
can.
on. I think for me, I work with children. It's part of what I do in psychotherapy, and I think we start at a grassroots level and we start to improve our self-concept. You mentioned it earlier, of female and male. It's both. But I think shifting that mentality from having the hero, we're brought up with stories, happily ever after, the hero will rescue us and take us away, and we've based our lives on those stories for centuries. And I think it's about starting with young children and allowing them to have a strong self-concept. No matter what their gender, they can move in and do what they want and achieve that.
I think that I sort of agree with what's been said, and I think change is going to happen on 3 different levels. You've got the individual level, and I think we need to work on our own unconscious biases, and I think we all have them. We need to work on our own imposter syndrome and be aware of those things. Then there's the organisational level, and I think things like less restriction around less than full-time training, having childcare at conferences, are things that you've already mentioned are important. And then the societal level, I think we need to address the way our culture is towards men and women, and I think we still are quite patriarchal. If you look at Scandinavian countries, they have a kind of lose it, use it basis when it comes to maternity and paternity leave, and I think that facilitates a culture where roles are more equal in a way. But the last point that I will make, I think it's really important that we have a more, we look at equality across the board. We don't just talk about women, or we don't just talk about sexuality. We look at it across the board, because unless we have that, unless we look at equality across the board, I don't think we can actually make change that's longer lasting. Because some people would say that actually now, the issue relating to women in medicine is somewhat resolved, if not resolved. And now the big problem that we have is to do with class. But actually I don't think you can split these things up.
No,
I think it's about taking them across the board.
Yeah.
Excellent, yeah. Talking about children,
Yes.
they're getting sicker, or am I
Here is the question.
Health anxiety is through the roof.
Here is the question. Yeah, are we busy? We're busy. We're busy,
Yeah.
but it's.
we're busy as
worrying.
adults.
We're busy as adults, but
Yeah.
we're busy as child therapists, because we're trying to provide what's been missing in children's lives. In my view, what has shifted in terms of our cultural and societal shifts in how we parent,
Wow.
and fundamentally that is causing children to feel lost, to feel anxious. And for me, that's a huge part of our work, is looking at the systems. Are children getting sicker? I think they actually are. I think
Is it because we've lost that parenting skills, that our parents did it so well? We thought it was effortlessly,
yeah.
but they had to work on it.
Yeah.
Do we underestimate the role of parenting?
We've lost our communities. I think that's the first thing I would say on it, is that we have a lot of professional couples moving away, further and further away. I'm one of those people. I moved further and further away from my family for love, really, and then you find yourself without that support. So we're trying. I see a lot of families trying to bring children up with 2 individuals, and they say it takes a village to bring up a child. That's really true. So this is playing out.
It's funny, isn't it? Because we have this actually extreme connectedness in terms of media and mobiles, and it's actually causing the opposite.
Yeah.
And that's not just in with children
Completely.
and health, or health in general. I think it's kind of happening in other spheres as well, like romance, like how,
Yes.
yeah,
Yes.
online dating and all of that. So
I mean, social media, having this connectedness via social media has its pros and cons, and everybody knows about them. But what's having that human connection, which children also need, they're losing. A lot of children are on their iPads, on their phones. And I, as a parent, yes, my 9-year-old knows the iPad better than I do. So, and there's two ways of looking at it. One, I'm really pleased that he's keeping up to date and connected in regards to his friends, his family, because that's how he communicates with his uncles who live abroad. And also he is able to keep up with the technological advancements way better than I am, someone who's a bit of a dinosaur. I know you said I look like 19, but I do feel like a dinosaur.
You don't look like a dinosaur.
And the thing is that connectedness, that human contact, means that those emotions of expressing yourselves or having that face-to-face contact is lost. Because when that child grows up, when they're 15, 16s, their hormones are raging. They want to have that connectivity on a personal level, or they're thrown out into the world to have resilience. I think that's the thing. The word resilience is what we are missing.
Resilience only comes through connection. We are designed for connection. A baby knows how to be cute in order to have its needs met, to have its survival. It will die without that connection, and we need that throughout our lives. We're the only species that needs love till the day we leave this earth. And if we are allowing our children to go down a path where they're connecting with a false, a screen, they can't be with the emotions that they're experiencing. And if they can't be with those emotions, then they can't manage those emotions. And then what we see in practice is we see the child having a meltdown, and the parent then, I can't deal with that when they come off the screen, because then we've got this parallel process of the parent and the child not being able to manage the emotional influx because we've cut off. So that's a really big problem that we're seeing.
I think there's almost there's three people in that relationship. There's the parent, the child, and then screen time, and that relationship is really hard to manage. And I'll hold my hand up to that. Sometimes when I am busy doing something, I probably will give the iPad because that's the best babysitter I know. But then it's trying to find that balance of getting your child off the iPad and having that connectiveness, whatever it might be. For my children, they just run with football. I mean, Fizzah was in my car earlier. It's a mess with football stuff in there, and that is their outlet. They just love the sport, and parents are finding their connectiveness regarding different activities, and that really, as we know, has a huge impact on mental health, physical exercise. But I often have this conversation with my mother, because she came from Pakistan with 3 children, not speaking a word of English. I'm the eldest of 5, and she often has said to me, looking after you guys was so much easier. I don't know how you're parenting. And I think the reason is because roles within a family have changed. Women are working, women are not staying at home. My mum was a stay-at-home mum. Her primal focus was just on us guys as 5. And so we'd come home, she'd make sure that the chapatis were made, the food was ready, she'd make sure that our breakfast was done in the morning, she'd be up before us, the house was clean, she would do our shopping for us, and then when we came to 16, it was, right, go and find yourself a Saturday job. And that was how we did it. And we sort of moulded our own way whilst trying to find the balance between our Pakistani background as well as this Western new ideology that we were learning, and trying to have that mishmash. Yeah, of course we had arguments at home. When we were younger, it was almost like, well, my white friends do this. Well, we're Pakistani, you're not doing this. And most arguments were either, resolved with a threat.
But there was a boundary, there was a line, Nighat, wasn't there? Which we need. We need that containment.
And threats don't work. I put my 2-year-old on the naughty step, and he got off it, and he goes, well, I'm bored.
Yeah. They have an opinion, which is really difficult.
Exactly. And my mother said to me, I would never let you guys have these opinions.
But there's something in, we were talking earlier about kind of having it all, having the career and having our children, and for ourselves as adults, we need that. To be a good parent, we need to be happy in ourselves. There is a real balance in the psyche of that. But equally, we have to acknowledge that whilst we are doing that, we cannot be fully attached to that child, giving them everything they need. We need people around us to do that. We need to foster teachers to be able to be good mentors. We need to foster professionals to be good mentors, to create people around our children. If we want to have this equality, then we've got to create communities for our children that are full of great mentors, because we can't give it all.
So do you think that because we are lacking mentors, or we're lacking all these community connectiveness, that children are growing up less empathetic? So we've got all these campaigns like #BeKind, #MentalHealthMatters, and are we losing empathy along the way? Or is it because we've got this outlet, which is social media, that we can spew out whatever vile views we have?
Well, children look to each other for help, and they're ill-equipped. So teenagers look to each other. That's why gang culture starts and things like that, because they look to each other, because if they're not having the attachments in their own life, they will look elsewhere, and they look to each other and they fuel each other. So that's where it's dangerous. You know, you've got to have someone in your life that you trust, you know, one attachment figure. And a lot of children don't have that. So that's what we see. So we work with families to create that. It's not about fixing a child, it's about creating a
So that's interesting you say
system.
That gang culture is on the rise, because where I practice, although it's a very sleepy village, there is a lot of gang culture. And we've had knife crime, in Dunstable and Milton Keynes, we've had knife crime, which is really unheard of in these areas. Is it because children are forming their own village?
Yes,
To
they're
nurture
creating
them.
their own communities. And troubled communities, because you bring into that community what you've unresolved, you know, what you haven't managed, what you haven't had the help to deal with, what you haven't had. I talked earlier about male therapists and male role models in the psyche for children. They're required. They may not have a father in their life or a mother in their life. So yes, they're seeking refuge in the safety of that. And that's where we've got to start creating more around children at grassroots level.
How can we do that, Gayle? You know, what's the sort of the easy steps to move forward? Is it to reduce artificial time with these machines?
Yeah.
Is it thought leaders? Is it community leaders? Is it faith-based, non-faith-based schools? I guess it's the whole...
It's all of it.
Yeah.
It's everything you've just said.
Yeah.
You know, I was out the other day and I was in a cafe with my daughter, and I saw a mum with a young baby, and the young baby was kind of doing that thing, you know, engage with me, and mum's on the phone, and you know, our society's changed in that sense. We are distracted. So yeah, we've got to get back to the old-fashioned connectivity.
And what about, I think there's a lot of pressures on younger children as well. I mean, I remember I didn't learn how to put makeup on. It sounds really silly, until I was in my mid-20s. Okay,
That's it. Yeah,
I see.
Your makeup is beautiful, by the way.
Thank you very much. But
This is the kind of conversation you don't have with men, Haidar.
I'll put on some makeup next time. Right?
But when, you know, walking on the street, I see really young girls, or you know, wearing makeup or wearing outfits that I don't know if I had a child that I would want her dressed like that.
Yeah.
And I think that pressure is coming from society as a whole.
Yeah.
And I suppose there is some regulation on the parental level on what filters down and what should or should not be done. But how much can we manage that pressure? Isn't that quite difficult?
Yeah, I think the social media fuels it, because children think it's real. You know, that's where we've got to educate them that it isn't real. It's a fake persona. It's a filtered image. It's adjusted. But also saying to them they don't need to grow up so quickly. You know, children are the wisest of beings, actually. They're more attuned we were more attuned at one point in our lives than we are now, sitting here now. We were far more attuned to what we needed. We were able to ask for it, and we kind of unlearned it, you know, and then we think we want to be an adult, and actually we don't. Yeah. None of us here really want to be an adult. No. You know, we can adult as much as we like, but actually, and people say, you work with children, you work with adults. I'm always working with the child. Yeah, because essentially we are. But yeah, I agree with you. I think children feel the pressure to grow up, and they're not equipped. Their brain is still developing till they're 25? Tell me what is the age?
That's the all the time.
all the time.
All the time. It never ends.
Yeah, it never ends. It really doesn't.
It never ends. And you know, we're changing. On a serious note, we're really changing the chemistry in our brains. You can talk more about this than me, but I see behaviours and things in children that I know are coming from the environmental factors and influencing their brain structure.
It conditions them. It just sort of puts them in a mould
Yeah.
And they find it more and more difficult to come out of that mold and that role.
Yeah.
And it's quite interesting moving forward in terms of medicine. Medicine is kind of seen as a serious profession, but really the best times that I've had as a doctor is when I have
Jokes.
a bit of jokes, basically.
Yes.
Bants,
Bants. Suddenly 10, 15.
Well, I've always been 15, 14. I'm stuck in that role. But the best times I've had as a physician and as a doctor is when we're having bants.
I totally agree with that. I think that this is the best thing about general practice, which I love about general practice, because you do get to know the whole family. You get to know them literally from cradle to grave, and then the relationships that form are actually deep rooted in an amount of respect and humour. Some of my best consultations are because they're humorous. In fact, a lot of my patients will leave the surgery and say to the receptionist, "I don't think I've ever laughed that much with the doctor before," and that's because I am very friendly and I'm very easy to get along with. And you sort of find that in medicine, humour does play a huge role. And I come back to the adage, laughter is the best medicine.
Yes.
And I sometimes have the most belly laughs with my patients. And it's because you're dealing with quite intimate situations. They're quite scary. I sort of recall a recent situation where a patient of mine, actually at this practice, we had a tough winter. She's palliative care, went to her house, and I said, "Oh, I'm really sorry." And she goes to me, "How long do you think I've got, doctor?" Which is a classical question a lot of palliative care patients ask. And the palliative care nurse was there. And I said, "Well, I'm just going to make up a name." But I said, "Mary, I'm really sorry. How long is a piece of string? I just can't tell you. But just have a chat with your family. This might be the last Christmas." Famous last words. Anyway, fast forward to January, she doesn't come in. February, she comes in, she walks into my practice and she says, "You definitely got that wrong, Dr. Arif. So you're not that good a doctor. Your prognosis was wrong." And I was like, "Do you know what? On these occasions where you didn't die, thank God I was wrong." And we had a really good laugh about it. And I think those are the sort of things that actually make general practice livable, bearable, and also make you keep coming back into work because of those relationships. A lot of the time when breaking bad news in medicine, when you're taught, and Fizzah, you get lectures and lectures on breaking bad news. And I've broken bad news. I've told a patient, the diagnosis has come back that you've got pancreatic cancer. And the patient will just say, "All right, doc, I've just had a good innings." And those actually are light half relief moments. And I think that there are doctors who are too scared to use humour in their surgeries, and they become very rigid to their training. You have to get out of that straitjacket of your training of a 10-minute consultation, or saying, "No, I've got to keep my patient at arm's length." Do you know what? Give your patient a hug when it warrants it. Cry with your patient when it warrants it. Definitely laugh with your patient when it warrants it.
So important.
I think it's to do with how we're trained overall. I mean, medicine is a factory production line, and I think it's quite difficult not to become wound up in your professional identity. And because being a doctor in society is equivalent to a certain status, it's kind of, you take that into your personal life sometimes quite a lot. And you know how families ask you about a funny rash. Well, my mum doesn't. I'm not considered a doctor at home, but you know what I mean.
The best consultations is when I'm stopped in, I don't know, the Sainsbury's aisle, and they'll say to me, "Dr. Arif, I've got some cottage cheese and I'm standing there looking at cottage cheese. And they're brilliant, because do you know what? That's what makes life amazing and fun, and it's not awkward. It feels that that person has had the confidence to come and even speak to you about it, and those ad hoc conversations where you have a giggle about it is actually quite good. And as doctors, junior doctors, I don't know about you, but I fished out all sorts of stuff from various orifices. And if you don't have a giggle about it...
Well, I just had a flashback to doing sexual health for 4 months, but I mean... I think
having done that myself,
part
you'll
of what
know
you're
what it's
saying,
like.
though, Nighat, is I think it comes to recognising in yourself certain qualities and what makes you happy and what makes you fulfilled, because I think that actually took me time. So you're able to use humour in your everyday practice. I think some people would find that hard, but for me, I think it took me a couple of years down the line after graduating, not that many years to be completely honest, to recognise that I find the restriction quite difficult sometimes, and I'm quite a creative person. I like writing, editing, as you know, some artistic stuff, maybe a bit of media stuff, and I needed to bring that into my professional life somehow. And I describe myself as a compassionate, empathic person, I hope, especially to patients. And I think you just have to recognise what's in you and use that to your advantage in a professional sense.
Use yourself. I think in the world of psychotherapy, especially if you're a psychoanalyst, which I'm not, I'm an integrative therapist, so I'm allowed to use different modalities, is what that means. But if you are a psychoanalytic therapist, you would be taught to be very boundaried, to not, hug your client, to never accept gifts, to never use humour. But you're using yourself to break down defences in psychotherapy. And the same in the medical world. You're trying to engage someone and connect, aren't you? So if you have warmth and humour, why can't you use that? I've laughed with clients many times.
Oh, they're the best
years.
Consultations.
They're just fabulous. We've cried, we've laughed. That's okay.
And the consultations where you have had the most open conversation actually do come from laughter, even if it's nervous laughter. And I completely agree with you. You have to find your boundaries within humour. Humour can go really wrong. I mean, it's like a lead balloon. If it's done wrong, it can literally blow up in your face.
And you can't take it back.
No, you can't take it. and I'm not going to lie, that's happened to me. Where I've seen somebody and I've just said, oh, that's a really beautiful girl. And the mother will look at me and say, that's a boy, Dr. Arif. So I've had those. And I think everybody...
Do you call that a fail? I call that absolutely normal.
Well, then I would laugh.
It's a normal daily occurrence.
Yeah, proper plus,
And for example, a patient will say to me, oh gosh, I have this horrible acne on my face, and I'll laugh and I'll say, that's not acne. And the patient will look at me. Because I think the thing is that as doctors, your extremes are very extreme. Like, for example, what might be normal for us is something that we see every day, might not be normal for the patient. And it's trying to find that boundary. So humour has to be used right and in a respectful way. I absolutely agree. But I don't think we should ever shy away from it. And doctors have this image of being straight-laced, boring individual, as I say, slightly on the autistic level, and I know I will probably get shut down for that again, but they are seen as somebody who can't have that warmth and that openness, but actually it makes you better clinicians.
Who are very factual and linear.
I would much rather see a clinician, having been on the receiving end as a parent with a sick child, a clinician who's able to have bants with me, as Dr. Heather was saying, than somebody who's going to give me the factual knowledge of the statistics of this and this, or the statistics of that. Mate,
you can't remember that.
I don't really care about the statistics, because that shows me you're hiding behind your figures. And that, to me, shows that there's a place of insecurity.
Mate, I want bants.
Yeah, exactly.
Come on, mate.
Then I'll feel really reassured.
It's true, though. It's true. I mean, there's points where you have to sort of get back into reality, and it comes back to that connectiveness, having just that. Forget about your titles. Forget about the fact that
we're humans here.
We're human. Exactly, we are
here.
humans. And I don't care if you work on the till, or you're a plumber, or you're a road sweeper. I will have that conversation with you at a level that's more comfortable with you. So I've stopped working with a 10-minute consultation. It doesn't work. And I've said that often to the Royal College, a 10-minute consultation, because you're again in that straitjacket of ideas, concerns and expectations. When a patient sits in with me, I say to them, what is in your mind? Tell me what brings you in.
But this is one way of looking at humour, because I think this is sort of doctor to patient, isn't it? We use humour in different ways. So I had an email recently after I'd written this article for the BMJ on the use of derogatory terms in medicine relating to ethnicity and gender. And they'd got back, someone had emailed me about how doctors use black humour and use these terms as a coping mechanism. So I thought that was quite an interesting way of looking at it, humour as a coping strategy.
As almost kind of degrading self as a coping
or degrading
strategy.
Others even.
Degrading others, Yeah, I mean, I think the psyche has always used humour as a defence mechanism throughout the generations, hasn't it? You only have to look at any comedian and look past their comedy to see their vulnerability. And I think humour can be harmful in that sense, because you can hide behind it, as you said, Nighat. You can hide behind maybe your data and your knowledge, but you can also hide behind your humour. I think there's a real balance there of actually being human and saying, do you know what, I've done that. I've said to clients many times, I've done that, you know. We're human, I've felt that feeling. And then they think, oh.
As long as it's caring, you know, as long as there's a caring dynamic in the relationship, that I think humour, whether it's you have race connotation, sex connotation, I think that's fine, as long as you've got a caring dynamic going on there, not a derogatory dynamic. And humans are very good at sensing, you know, that they're being taken the piss out of.
Yeah. The weird thing is, sorry to interrupt you there, that laughter is universal. Like everybody laughs the same.
Everyone knows how to laugh.
And everybody knows how to laugh. Yeah. And I find that mind-blowing. You could go into the Outer Hebrides and that person will laugh, possibly at a similar joke. So someone falling over. You know, like we're laughing now.
They do laughing therapy in Japan. Come on, this is a thing.
And, you know, we know that endorphins and serotonin and all of those happy hormones are released when we laugh. And so surely if we can make that connectiveness as clinicians, just on that basis, then there is that caring that will run throughout that. That's why comedians are loved. And I think at the root of it, we all have vulnerabilities, and doctors like to be liked. That's why they're doctors.
Yeah. And, you know, through vulnerability comes healing.
Yes.
You know, that is the actual healing process, that, you know, you do have to go through pain, suffering, vulnerability, and after that comes the healing. And my personal opinion is, if we are vulnerable in that doctor-patient relationship, it does help the healing. But are we vulnerable enough? And you know, the answer is no, we're not.
I don't know if it's just about vulnerability, though. If you think about it in practical terms, compassion takes time, and also doctors who are burning out, I think, are less likely to be compassionate because your priorities are then shifting.
Yeah, I think that's a great point. We've got to support our professionals. As a psychotherapist, time and time again, I see professionals in all areas, medical, educational, burning out. And I know this is something that we spoke about earlier, but we've got to support that, because we lose our ability to contain and be compassionate. It's the same in parenting. If we don't look after one another to do the jobs we do, how can we do them? You know, we've got to be able to support our medical teams to think about that burnout, to think about the trauma that we're talking about humour, because if we didn't have humour, we'd be very traumatised. We deal with very traumatic news and situations.
We would be, and this is where I think burnout actually can be prevented, where if you do have that humour. I mean, before we started this podcast, Fizzah was saying, you know, everybody at your practice, you know, it's really lovely. And I do. My door is open. I could have the receptionist, the cleaner, anybody. I will know them. They can come in and we can have a joke or a banter with each other, very quick. Those little tiny moments of where you have a little bit of laughter are actually what then gives you a bit of relaxation. You laugh, your serotonin is really, you're happy, and you have that connectiveness, even if they're minuscule, but it allows you to have those outbursts without having to feel, okay, I'm just seeing exhausting patients or exhausting people who are coming in and taking up my time. Your secretary isn't burning out. And I will actively make time for my secretary and my PA. We have a coffee with each other, we'll chat things through. And that isn't just related, I'm not the only one that does that. I know millions and millions of or thousands of doctors who do that across the world, and millions of etc. And what we need to do is keep that humour alive by picking up things that, you know,
the connectivity.
Exactly. My PA downstairs sometimes has the worst haircut. I'll be like, Mo, that's the most gorgeous haircut I've ever seen. She won't mind me telling you that. And we have a little giggle with each other. Or she'll comment on my hijab.
We're coming towards the end of the podcast, and I just wanted to finish off by saying, also asking you three ladies, how do you deal with your burnout kind of de-burnout process?
Well,
what do you do?
I think we've known each other well enough that we laugh a lot.
Yeah.
We definitely do. And I think I don't take myself too seriously. The minute you start taking yourself too seriously, or you start thinking that you're amazing at your station, actually the downfall is harder. So I try and take each step at a time. And for me, I think the biggest thing is that faith plays a huge part in what I do. So I need that connectiveness to be able to switch off from everybody else. And my faith then grounds me. As well as my 2-year-old, he grounds me. He doesn't care what I do.
Literally, he will ground you. Yeah. I think for me, it's very similar. It's humour. I have to have humour, and I have to expand my mind. I have to open up. You know, when you're dealing with trauma, and I do a lot of trauma work as you do, you've got to expand your mind to other things to have hope and have reason for change. So for me, it's my research, it's doing things like this, it's exercise, it's being with like-minded people. That's what gives me my life energy.
I think for me it's taken time and experience and learning, and the most important thing has probably been learning about myself, acknowledging that I like a bit of freedom in my career, I like variety, I like creativity, and bringing those things into it. I've worked less than full time to try and bring in more of a family life because I've recognised that that's important to me. I've created ways of doing other projects, like kindly Dr. Arif over here invited me here today, and I think that's all important for my kind of well-being as a whole professionally. But then there's all that stuff, isn't there, like yoga and a bit of meditation, baking cakes, all of that fun stuff too.
I think that's great. Is the variety is the spice of life, and being clinicians, if you have that variety. For example, I've worked every day, but I've only done 3 clinics this week. Obviously my patient aren't happy about it, but I don't feel tired or exhausted because I've met with individuals outside of medicine, people who I would never dream of meeting if I just stayed stuck in my surgery. So variety is definitely the spice of life, and that is the thing that prevents burnout.
And I think as a doctor in training, I think you also have to recognise, I mean, we were sort of talking about this before, about being able to recognise what is externally being, in a way, imposed on you and what you are and how to express yourself. And then we were also talking about professional and personal boundaries, and I know around this table we vary in this, but I've created a real distinction as much as I can between personal and professional, because it just makes, I don't know, I think it just gives you that mind space to come back refreshed.
Holds you safely, definitely.
Well, thank you so much for sort of landing us on this sort of safe note. Thank you so much.
Thank you for having us.
Thank you.
Thanks for listening to this instalment of the Surgical Spirit podcast. For all the latest in the world of surgical spirit, don't forget to follow on Twitter at The Third Eye Doc, and catch me on Facebook at the page The Third Eye Doctor. You can visit the website at www.thethirdeeyedoctor.co.uk for more information on the work that I do. And please send us feedback and questions and suggestions for the podcast. It's always a pleasure to hear from you. I've been Dr. Haidar Al-Hakim, and I'll see you next time.